Hello friends, welcome to this session. Now we are having rapid revision of the subject community medicine, and we will be preparing to our best for our upcoming exam on 17th of January 2026. Okay, so here we'll be trying to again understanding the concept, trying to identify, highlight the important areas, the important keywords from where mostly the questions are asked from us in examination. As we had already discussed in our live classes, again I will say that the important topics from where commonly the questions are asked is number one, that is the health, demography and contraception. Demography and contraception. From here, around 4 to 6 questions are asked. Another important topic is that is the prevention in pediatric and obstetric and nutrition. Again, from here, the 4 to 6 questions are asked from us in the examination. Then nowadays there is an increasing importance of these topics as social and mental health, health education, communication and health planning and management. Around 4 to 5 questions from these three topics are asked, and the remaining 8 to 10 questions are asked from diseases and related national programs. So these are some of the important, we can say, the high yield topics from where commonly the questions are asked. Otherwise, the questions are being asked from other areas also. On an average, we see that around 30 questions are supposed to be asked from this subject, but invariably around 35 to 40 questions are asked, and 30 to 33 questions are the core questions of this subject, and the remaining 5 to 7 are overlap between the pediatrics, maybe with obstetrics, biochemistry and pharmacology. So quickly, now starting with our first topic of discussion, and that is prevention levels. Okay, so here the scenario will be given and you have to say that what is this level of prevention is. So we should be knowing the basic 4 levels of prevention. The first is that if the risk factor is trying to be avoided or absence of the risk factor, then it is your primordial level prevention. Okay, so presence of occurrence of the risk factor, prevention of occurrence of the risk factor or the causative agent, it is what is primordial level prevention. But if risk factor is present but presence of the risk factor, the causative agent, we are trying to prevent the disease, it is called as primary level prevention. And if this is focusing for individual person, it is called as a specific, and if it is for the whole community, it is called as health promotion. Okay, then what is this the early diagnosis and the treatment, that is what is called as the secondary level prevention. Okay, so early diagnosis and treatment is your secondary level prevention, and this is ultimately leading to the disability prevention, prevention of the complications. And if we are managing the complications or the managing the disability or trying to prevent the disability or doing the rehabilitation, that is what is all tertiary level prevention. We talk about in which phase of the pathogenesis, primordial and primary, before the disease develops. So it is in a pre-pathogenic phase, while the secondary and the tertiary, it is in pathogenic phase. The secondary is in the early pathogenic phase and the tertiary, it is in the late pathogenic phase. Okay, then if we talk about the identification, that you have to look in the scenario. If risk factor is absent, it is what is your primordial level prevention. Okay, now if complications are present or the disabilities are present, then no doubt it is the tertiary level prevention. And if disease is absent, it is maybe primordial, maybe primary. And remember, in the secondary, sometimes the disease is present, you are trying to early detect, and if it is sort of an annual health checkup, it means the disease is absent is still. If you are doing a screening or doing a checkup, it is your secondary level prevention. And these are some of the examples, and we should be knowing that what is a different level of prevention in this. Now coming to our the And this is what is the flashcard I had already given to you, and this is again flashcard. The important keywords, you should be going through this to identify that which activity is considered as in which level of prevention is. Now if you come to the vaccine, again it is a very important topic from our examination point. The first question, that in which situation we are giving both vaccine and immunoglobulin together, that is active and passive immunity is given together. Okay, so active and passive immunity, it is given together in the 4 diseases which you can remember as DR, doctors are treating hypertension, that is diphtheria, rabies, hepatitis B and tetanus, but it is not given together in measles. Okay, and if in the measles we try to give the first vaccine, then we have to wait for at least 2 weeks. After that we can give the immunoglobulins, and if we are giving the first immunoglobulin, we have to wait for at least 3 months before giving the vaccine. Now type of the vaccine is again very commonly asked area. Then see carefully that they are trying to ask of which type of the vaccine. Okay, so only live vaccine we can remember as our mnemonic as a BMR of yellow dirty chicken, and the killed vaccines, only killed vaccines as mnemonic as an Harpic. Then both live and the killed vaccines, this is important, and this again we can remember with the mnemonic, that is hello G, take the pick please. Okay, now here it is the hepatitis A, H stands for the hepatitis A, J stands for the Japanese encephalitis, T stands for typhoid, then P it is for the polio, influenza, cholera. Okay, so these are the vaccines which are available in both live and the kill form, and these are the vaccines which are creating confusion in the given question. So see the question very carefully. Now in polio, always remember that live vaccine, it is also known as Sabin, or it is a oral polio vaccine, and the killed vaccine, it is also known as SAC, K for the killed, and the SAC, it is K for killed vaccine, it is inactivated polio vaccine. Then others are the toxoids, these are the purified exotoxins, and tetanus and the diphtheria, these are the 2 vaccines in the toxoid form in universal immunization program. Then polysaccharide vaccines are the pneumococcal, meningococcal, Haemophilus influenza B and the killed typhoid, but in our program we are using the conjugate form because they can be given in a children less than 2 years of the age, where polysaccharides are contraindicated. And the pneumococcal and the HIV vaccine what we are using in our program, they are conjugate type. Okay, remember this point. Okay, then pentavalent is the 5 vaccines, that is DPT, hepatitis B and Hep. So these are the 5 vaccines including in a single prick, that is pentavalent vaccine is there. Then HPV vaccine for prevention of the cancer cervix, it is a quadrivalent, it is against for the strains of 6, 11, 16 and 18, and out of that 16 and 18 is important, which is preventing against the cervix cancer. And nanovalent, it is preventing along with the cancer cervix other warts as well as the penile cancers also. So 6, 11, 16 and 18 same as a quadrivalent. In addition, it is having 31, 33, 45, 52 and 58. So these are for 9 strains, nanovalent vaccine is there. Now strain of the vaccine is again important from our examination point, because they can be asking either direct strain. With the strain they can ask us to identify the vaccine, or they can be asking us the direct match the correct or incorrect pair. Okay, so BCG, B stands for alphabet B, C and the D, Danish 1331, Danish 1331. Then we are having the measles. Measles, it is your Admoston jagrab. Okay, so me is the ma, it is saying ki bhai jaagte rehna, Admoston jagrab strain. Mom is the modified version of the ma. Okay, so modified version. So the current we can say the TV or serial or बच्चों का जो कार्टून चैनल है, that is Tom and Jerry, so a Gerald line strain. The rubella, it is R for rubella, R827/3. Yellow fever is a disease which is not seen in India, so it's a 17D disease which is not present in India. The chicken pox, oh you had a chicken pox, varicella, this is OKA strain is there. Now Japanese encephalitis, remember that is the live vaccine strain, it is SA1414-2. Now we are not using in our national program, remember this point, and we are now using the killed time, and that is the strain is having the Kolar strain. Okay, so Kolar strain it is there, and the Kolar strain we are using, and that is available by the brand name of Janvac. Okay, now polio mein we are having now bivalent OPV, the strain is P1 and P3. P2 was removed because P2 was causing what? It was causing the vaccine derived polio virus. Okay, so it was removed from the OPV, but is still in IPV. It is trivalent, having all P1, P2 and P3, and this switch was on 25th April 2016. Okay. Then we are having the strain of the dengue vaccine as quadrivalent. The CYD-TDV strain is there, and rotavirus is RIX 4414. Now, a universal immunization program, a very important area from where the question is asked, and this was started in 19th November 1985, and the schedule what we are giving is called as National Immunization Schedule. So, first question, when we are starting our vaccination to our babies under this UIP, we are starting right at the birth. And in the hospital deliveries, we are giving the BCG vaccine, then we are giving the oral polio vaccine 0 dose, okay, that is given at birth, and the hepatitis B birth dose. But if it is a home delivery, so we cannot give the hepatitis B birth dose because it is by injection, so it is not given at all, because within 24 hours of the birth we have to give. But BCG, it is a very important vaccine. So, whenever the baby is coming next a visit for vaccination, it is given in the next visit, and OPV 0 dose can be given within next 15 days. Okay, why within next 15 days? Because the minimum gap between the two vaccines should be 4 weeks. Okay, especially if they ask for the live vaccine, we can be keeping as 3 weeks also, but on an average is the 4 weeks. So, within 2 weeks we are giving the OPV, because the routine schedule we are starting at the 6 weeks. So, 6, 10 and 14. At a gap of 4 weeks, we are giving the first, second and the third important vaccine doses. Okay, and you can remember as a 5-3-5 rule. So, 5 vaccines at the 6 weeks, that is first dose pentavalent, the first dose of the OPV, first dose of the rotavirus, as well as the first dose of first fraction of an IPV and pneumococcal vaccine. Now, 10 weeks where it is only the pentavalent, OPV and the rotavirus second doses, and 14 weeks where it is the third dose of pentavalent, OPV and rotavirus, as well as the second dose of IPV and pneumococcal vaccine. Okay, then we are going directly to 9 completed months. Always remember, the vaccine which we are starting at a 9 completed month, we cannot be giving earlier. Okay, so if a question is given that what vaccine you will be giving to a baby of a 4 month or the 5 month, so we are not giving the vaccine, but we are giving at a 9 month. Okay, so 9 month we are starting a very important vaccine, that is measles containing vaccine. Okay, and usually it is MR, but some states are giving MMR also. Then booster of pneumococcal vaccine, then first dose of the Japanese encephalitis we are starting, then the third dose fraction of IPV we are giving, and the vitamin A we are starting. Now remember, the vitamin A, it is started at a 9 month, it is a prophylactic. Okay, but if they say that a baby of a 4 month or the 3 month is coming with some deficiency symptoms like a bitotic spots or night blindness, in that case we can be giving earlier, but prophylactically only it is 9 month plus, because baby is having breastfeeding, so through the breast milk the baby is getting vitamin A from a mother. Okay, so it is still 6 months exclusive breastfeed, and it is a fat soluble vitamin, so it is still remaining for another 3 to 4 months, and we are starting at 9 months prophylactically. So 9 to 12 month के बीच में we are giving the first dose, and that is 1 lakh international unit or the 1 ml, and then every 6 monthly till 5 years another 8 doses of the 2 lakh each we are giving, or 2 ml. But this is only if a baby is normal growing. Normal growing means a weight is more than 8 or 8 kgs. But if a baby is malnourished, more than 1 plus but less than 8 kgs, that particular dose will be 1 lakh international units only. Okay, so the prophylactically the total 9 doses we are giving, and the total 17 lakh international unit of vitamin A we are giving, because vitamin A deficiency is the most important cause of blindness in children. Then 1.5 year again the 5 vaccine, the booster of OPV, then first booster of the DPT, the second dose of measles containing vaccine, the second dose of the Japanese encephalitis, and vitamin A to be continued. At 5 months we are giving second booster of the DPT, then 10 year we are giving the TD. Remember, it is not the TT, because we are adding some amount of the diphtheria also, which is preventing the baby, because now it has been seen that diphtheria is happening in the older age also. But remember, after 7 years we are not giving the a full dose of the diphtheria, so we are not writing as a capital D, it is a small d. Okay, so T capital full dose of tetanus antitoxin, but it is the D, that is small amount of diphtheria toxin we are giving. Okay, So this is about the baby vaccination. The pregnancy may we are giving the TD vaccine, okay, and how many doses? If she is a primary gravida conceiving for the first time, the 2 doses we are giving. The first is whenever the patient is coming for the confirmation, or as soon as the patient pregnancy is confirmed, and then the second dose is given after a minimum gap of 4 weeks from the first dose, but preferably the second dose to be given at least the 3 weeks before the expected delivery for a good effect at the time of the delivery. And multi-gravida may she has a previous delivery within the 3 years back, only the single booster dose is given, but if she has a delivery more than 3 years back, then again we have to give the 2 doses. Now, delayed immunization, this is again an important area, and it means if a baby is not receiving the vaccine as per the schedule, how long we can give this vaccine, okay. So, till 24 hours we can give the birth dose of the hepatitis B, the till 15 days or 2 weeks we can give the 0 dose of the OPV, till 1 year we can give the pentavalent hepatitis B, IPV, pneumococcal and the BCG, and okay, then 5 years tak we can be giving the OPV, measles containing vaccine or measles MR or MMR, vitamin A. Yes, it is a little bit difficult, but we have to remember. And till 6 years we can give the hepatitis B, Hep Haemophilus influenza B. Till 7 years we can give the DPT. Then till 15 years only the live JE, but if you are giving a kill JE, it is only given till 2 years. Now there is a little update or change. So those who had attended the classes earlier, now please note this, that rotavirus, now we see the first dose can be given up till 1 year of the age, okay. Earlier we used to say till 15 weeks, but now we say the first dose can be given till 1 year of the age, and the last dose to be completed as soon as possible after giving the first dose, okay, but maximum to be given up to 2 year of the age, okay. And TD, it is given till 16 years as well as in the pregnancy. So this is about the delayed immunization. If a gap is more than 4 weeks, we are not going to restart, we have to resume, means we have to give the leftover doses, okay. And this is how I try to frame a mnemonic that how to remember this delayed immunization. Then the diluent of the vaccine, the 2 important diluent we are using, the sodium chloride or distilled water. So, normal saline of the sodium chloride, it is used for BCG, that is a very important vaccine, and the distilled water, it is used for measles and or the MR or MMR vaccine. The dissolved vaccine should be used within 4 hours, okay. If they are specifically asking for the J, it should be within 2 hours, especially for yellow fever to be used within 30 minutes. Okay, why? Because this to avoid the toxic shocks syndrome. Now, doses, it is on an average is 0.5 ml. So, some are the exceptional like BCG, it is 0.1 ml, IPV 0.1 ml, and OPV 2 drops, rotavirus, because rotavac we are using in our program, it is 5 drops, and vitamin A, it is 1 ml is equal to 1 lakh. So, according to that, less than 1 year baby, it is 1 ml, more than 1 year baby, it is normally growing is 2 lakh or 2 ml we are giving. Okay. But specifically if they are asking about the dose of the BCG in a baby of less than 1 month, then it is still less than the 0.1 because skin is very thin and it is 0.05 ml. But if nothing has been mentioned, they say simply ask what is the dose of the BCG to a baby, it is your answer should be 0.1 ml. Okay. Now, routes of administration is again very important. It could be your image based question also. So, very important vaccine given by the nasal route is live influenza. The oral is OPV, rotavirus and vitamin A. These are the 3 vaccines of our national program. Then intradermal is a very important. If the left shoulder they had mentioned, it is your BCG, okay. In the left deltoid we are giving the BCG, and this is at birth, okay. But at a 9 month we are giving this IPV third fraction also here. Just a minute. So, intradermal we can be giving the BCG as well as the IPV and the rabies. So BCG, it is given in the left shoulder. Okay. Then subcutaneous, very important vaccine which is given in the right shoulder. It is your measles containing vaccine, or the measles MMR or MR vaccine is there. Okay. And the rest of the vaccines, they are given through intramuscular route. Okay. Now this image is very, very important, and they can be pointing out the arrow that what vaccine is given on what age, okay, and what site. So if they say that in the left deltoid at a birth, okay, or till 2 months, 3 months, 4 months, we can be giving this BCG. But if they are asking that baby had received the previous vaccination as per the schedule, now coming at 9 months, so what vaccine we are giving at the 9 month in the left shoulder? It will be the third fraction of IPV, because the first and second fraction we are giving in a right deltoid, okay, because first fraction we are giving at 6 weeks and the second fraction we are giving at 14 weeks. At that time there is a BCG ulcer or lesion, it is there on the left deltoid. And why the third fraction is not given in the right side? Because at 9 months in the right deltoid we are giving the measles containing vaccine. So this third fraction we are giving in the left shoulder. Okay. And earlier we used to give the JE live also at the 9 month in the left shoulder, but now we are not using the JE live, we are using a JE kill which is given intramuscular. So at the 9 month in the left thigh, because intramuscular less than 2 year, we are giving in the anterolateral aspect of the thigh. So JE killed vaccine we are giving in the left thigh at 9 month. Okay. And 9 month we are giving the pneumococcal booster also, so it is given on a right thigh. 6 week pe pneumococcal booster first dose, again right thigh. Okay. But 6 week mein pentavalent intramuscular we are giving in the left thigh. Okay. So 6 week pe we are giving pentavalent in the left thigh, then 10 week पे second dose of pentavalent in the left thigh, 14 week पे pentavalent in the left thigh, birth पे hepatitis B birth dose we are giving in the left thigh, as well as the 9 month पे जो JE killed and 1.5 year पे second dose of JE killed we are giving in a left thigh. ठीक है, right thigh पे we are only giving the pneumococcal vaccine, and right deltoid पे we are giving the measles containing and the IPV first and the second fraction. So be very careful that what is the site and at what age we are giving the vaccine there. And orally in our program we are giving the OPV, rotavirus and vitamin A. So this is a very, very important image and very commonly asked from us in the examination. Now coming to contraindication of the vaccine, again important area, that pregnancy may we say that all the, you have to answer as per this, all the live vaccines are contraindicated, but all the toxoids can be given safely. Yellow fever, if it is required, can be given, but rubella, it is having an absolute contraindication. So always see the choices and you have to choose the best possible answer from the choices. Now if a baby is on steroids and if you have to give the live vaccines, ideally should be contraindicated, but if we have to give, we can stop the corticosteroids for minimum 4 weeks. After 4 weeks we can give the live vaccines. We can again wait, and there is a little update here is that we can start even after a gap of 2 weeks. So just make it updated that 4 weeks before you have to stop, that give the live vaccines, wait for 2 weeks, and after that 2 weeks you can restart. Okay. Now patient, if it is HIV positive, if a baby is asymptomatic, in the developed countries all live vaccines are contraindicated, but in the developing countries like India we are giving the 3 live vaccines to an even HIV positive baby, and that is BCG, measles and the OPV. But baby should be asymptomatic. But if a baby is symptomatic with HIV, then BCG we say it is contraindicated, otherwise there is a risk of miliary tuberculosis. If there is a history of anaphylaxis to the previous doses, the next dose to be avoided. Then egg allergy may, the influenza is a vaccine which can be very easily avoided, because other vaccines, although they are having contraindicated, but if they are mandatory, then it can be given as the rabies, measles or the yellow fever. But yes, influenza vaccine can be avoided. Now active neurological disease hai to pertussis is avoided, but as pertussis is not available separately, so we can be avoiding the DPT vaccine. Now after giving the vaccine, there is some dangerous side effects are there. The paralysis can happen after giving an OPV, and this is because of the P3 strain, which is leading to vaccine associated polio paralysis. Okay. Then most common vaccine which is causing anaphylaxis is hepatitis B. Other vaccines are the DPT vaccine or the tetanus vaccine also, which is causing the anaphylaxis. Now, please be very careful about the DPT side effects. If there is an anaphylaxis or the active neurological disease after the previous dose or after this dose, the next dose is contraindicated. But if there is a hypotonic hyporesponsive episodes, the baby is having hypotonia but vitals are stable, no shock, then the next dose can be given safely, okay, because it is being resolved in its own, no treatment is required for this, appearing within 48 hours of the vaccination. But if a baby is having the inconsolable cry, continuously crying for more than 3 hours, or having a temperature of more than 39 degrees centigrade, high grade fever, in that case they say now the DPT, it is not contraindicated. Earlier we used to say it is contraindicated, but now we say DPT, it is not contraindicated. Next dose can be given with precaution. Better होगा कि you can replace the whole cell pertussis with the acellular pertussis, which is having a lesser chances of this inconsolable cry or high grade temperature, okay. But if it is not available, then we can give the DPT with precautions, okay. Then intussusception, it is commonly seen with the rotavirus. Toxic shock syndrome is very commonly seen with measles. Thrombocytopenia with the MMR vaccine. Then killed influenza, say Guillain-Barré syndrome is there, okay. So these are very important side effects, okay. Now storage of the vaccine, the very important the instrument for storing the vaccine, it is your ice lined refrigerator, and its temperature is around +2 to +8 degrees centigrade. What is the reverse cold chain is the transfer of the stool sample to the lab of a suspected polio case. It has nothing to be connected with your vaccination, okay. So this is reverse cold chain, and its temperature is continuously monitored twice in a day, either by dial thermometer or by the alcohol thermometer, okay. Now, from this ILR, the vaccines are transported to the periphery in the transportation boxes, which are called as the vaccine carrier or the day carrier. This is commonly used, which is having 4 ice packs in this. Maximum chances of the cold chain failure is happening in the transportation of the vaccine from the PSC to the periphery, to village or subcenters. But chances of the vaccine failure, okay, you are giving a vaccine, proper cold chain is maintained, still antibodies are not formed. It is because of presence of maternal antibodies which are not allowing this vaccine to work. So cold chain failure is a transportation, the vaccine failure is maternal antibodies. Don't confuse in these two questions, okay. Now the lowest storage center is the primary health center, where all the vaccines including the OPV, measles and the rotavirus also is stored in a ILR only, because maximum duration of the storage is still 1 month. Deep freezers we are only using for preparation of the ice packs, but at the district hospital onwards, we are segregating these vaccines because we are storing the long term for more than 3 months, and vitamin A is stored at a room temperature. The minus temperature mein, freezer mein, it is OPV, measles and the rotavirus we are storing. The rest all including the diluents we are keeping in +2 to +8 degree centigrade. Now another important point is that we had already written this in the extra H point also, that if there is no space available in the ILR, so diluent we can keep outside, but at least for minimum 24 hours before its use, it has to be kept in ILR at +2 to +8 degrees centigrade. One another important point is that in the ILR, the bottom temperature, it is the lowest one. So heat sensitive vaccines like an OPV, it is kept at the bottom, and the to be on the upper side, the temperature is little bit high. So freeze sensitive vaccines are usually kept towards an upper side of the ILR. That is hepatitis B, it is we can say the most freeze sensitive vaccine hai, so we are keeping on the upper side, and then on the top is a diluent also, and the most heat sensitive vaccine hai, which we are keeping at bottom, it is your OPV. So this is about your ILR, and the most heat sensitive vaccine is OPV. Even if a dissolved BCG is given in your choice, that is the number 1. If it is not there, then you can go with the OPV. The most freeze sensitive vaccine is hepatitis B. If it is not in your choice, you can go with pentavalent, then followed by the DPT or the TT. Now if a vial is given to you, and if you want to check whether it is destroyed by the heat or not, so we are looking for this vaccine vial monitor sticker. So VVM, it is used to check for the heat damage of the vaccine and the inner square. Remember, it is not an inner circle circle, inner square if it is a white or very light blue, and if it is changing its color, it is becoming little blue but lighter than the outer one. Grade 1 and the grade 2 we can use, but should be within the expiry. If it is beyond the expiry, obviously even in a grade 1 and grade 2 we cannot be using, but if it is the same color or the darker color, the stage 3 and stage 4, we have to discard these vaccines. Okay, and the freeze damage of the vaccine, it is checked by shake test. Open vial policy means once you open the vial, if it is in a already in the liquid form, properly stored, the date of opening is written, then we can be using till 4 weeks. So question is asked, which vaccine follow an open vial policy, which doesn't follow. So common point is that if a vaccine is available in a powdered form and we had used any diluent for that, in that case it is not applicable, because once you had diluted, within how much time, within 4 weeks we have to use this. And we can remember this with the mnemonic like a BB ki ye jawani hai dar ke chal mar jawa. So these are the vaccines which we are diluting and in any of the diluents, so they are not following an open vial policy, and the rest of the vaccines it is following. Now listen carefully. Then if the question is asked as a JE may the killed it is in the liquid form, so it is applicable or it is following an open vial policy, but the JE a live vaccine which is in the powdered form, so it doesn't follow. Same is with the rotavirus. If it is simply say the rotavirus vaccine, because what rotavirus we are using in our program is a rotavac, and यहाँ पे VVM it is on the body, so it is following an open vial policy. But if a rota it is used, okay, not very commonly is used, but if a question is saying rota it is not following an open vial policy, because here we have to dilute in a buffer solution before giving this to the baby. ठीक है, but simple अगर rotavirus पूछा है तो yes, it follows your open vial policy. And herd immunity means that vaccination of others can protect you or not. There is no role of the herd immunity in the rabies, okay, and the tetanus, an individual has to receive its own vaccination. But for measles, pertussis and chickenpox, yes, if vaccine coverage in the community is more than 90%, it is breaking the chain of transmission. But for the polio and mumps, to break the chain of transmission, the vaccination coverage should be 80 to 85%. Now intensified mission Indradhanush is a program which targets for vaccinating almost up to 100% of the children for the 12 vaccine preventable diseases. Okay, so we are giving the vaccine in our program for 12 vaccine preventable diseases, but remember, if they talk about the pan India, it is only for 11 diseases, because the 12th vaccine, that is JE, we are only giving in some endemic areas like part of the Uttar Pradesh, then West Bengal, then part of Karnataka. So these are Jharkhand, so the Bihar. So these are the some areas where we are having endemic of Japanese encephalitis. Now we are doing a survey to find out those children who are not receiving the complete doses, who are left out, and this survey technique is used known as a cluster random sampling technique, and this is for the immunization survey. And here we are doing the survey of children of 12 to 23 month of the age group, okay, and for the left out doses, and those children we find that they are left out, then we are giving the remaining doses, okay. And this is also known as 13 to 7 cluster. 13 to 7 cluster means that there is the 30 groups. So 30 clusters or 30 groups are there, and in each group we are having the 7 children, okay, 7 children in each group. So it is called as 30 into 7 cluster, that 30 groups of the 30 clusters are there, and in each group we are having 7 children. Now seroconversion time means that how much time is required for antibody to develop after giving the vaccine. If seroconversion time is less than the incubation period, then post exposure vaccine will not be it will be effective, okay. But if a seroconversion time is more than the incubation period, then post exposure vaccine is not effective. Like cholera, typhoid, hepatitis A, it is not effective, but yes, in the rabies, tetanus, measles, chickenpox, it is effective, because seroconversion time is less than incubation period of the a vaccine. And these are some one-liner important points, like if a single vaccine is allowed at 9 months of the age for the first time visit of a baby, it is a measles vaccine. Then measles catch-up campaign age is 9 months to a 10 year. If a child come late for the measles vaccine, normally we are giving a first dose at 9 to 12 and the second dose after 6 months at 1.5 year. But suppose at a 2-year age the baby is coming for the first time, we cannot wait for 6 months. So at a gap of 4 weeks we are giving the 2 doses of the measles vaccine. Then agar no scar is after giving the BCG, and if you are having a record available saying the BCG is given, then reassurance to the mother. But if no record is available, you do the Montoux test. Okay, if Montoux is positive, it means either the vaccinated or had a latent infection, then reassurance, there is no need to give the BCG vaccine. But if Montoux is negative, no record is available, no scar, in that case we have to give the BCG vaccine. Now, can we have a breastfeeding immediately after the OPV? Yes. Can we give the OPV and rotavirus together with vitamin A? It is big yes. And this is the summary of all these 12 vaccines that we are giving in our national program. So, I try to summarize the important points about these vaccines. So, go through these important points. You already had your flashcards separately also, and you might had already saved, and this is very important for your quick revision of the vaccines before your exam. Now, in the extra edge point, this is, remember, this is a SAFVAC. It is software for reporting the adverse events following immunization, and this is your logo. Okay, logo of this SAFVAC. Then there is UVN app, जैसे कोविन ऐप था for COVID vaccination tracking. So it is for tracking of vaccination records of children of 0 to 5 years as well as the pregnant patients under a UIP program. So this is your logo for a UVN app. ठीक है. Then स्लोगन है कि 5 साल में 7 times we have to give the vaccination. Now, conditioning of an ice pack, it is a little bit a higher point. Like when you are removing the ice pack from deep freezer, then don't put immediately in the transportation vaccine carrier boxes, because it is having minus temperature. We have to bring down the temperature of the ice pack to 0, otherwise the vaccine will be destroyed. Okay, because जो free sensitive vaccines are like DPT, TT, it will be destroyed. So we keep the pack for a few minutes outside, and how we come to know that it is now done, conditioning is done, that some of the water droplets are forming on the surface, and when you shake the pack, this ice starts melting, and उसको जब आप हिलाते हो तो उसकी आवाज आती है कि ice अंदर move कर रही है. ठीक है, this means now the conditioning is done and you can keep the pack in the cold boxes. So cold boxes में you are keeping the not unconditioned pack, you are keeping the conditioned ice packs. Holdover time means in the ILR, vaccines are there when suddenly suppose electricity is out. So for how much time the vaccine is safe, and when the vaccine is safe, till the temperature is reaching to the 8 degrees centigrade. So it is the time taken by the equipment to increase the cabinet temperature at the time of the power cut to the maximum temperature limit of the equipment, that is up to plus 8 degrees centigrade. Now VVM types, we are having the different types denoted by the numbers. ये numbers क्या है? Numbers days में है कि how many days. Suppose this vaccine is kept at a normal temperature of 37 degree outside. So within how many days it will be reaching to the discard point, means reaching to the grade 3. So this is what is the VVM types. ठीक है, like VVM2 means within 2 days में if you are keeping outside, it will be destroyed. Like VVM30, it means it will take 30 days to reach the vaccine to a discard point. Then storage of diluent we had already talked about, and so this is all about our second topic of vaccination. Now coming to our next topic, that is concept of health and disease. Just a minute. Now we should be knowing what are the components of PQL and HDI. Physical quality of the life index, the 4-letter word. So life expectancy starts at a bigger point at 1 year of the age. So IMR is a part of that, and the literacy rate. Okay. While in the HDI, human developmental index, the life expectancy starts at birth, income is a part of that, and knowledge. And the range, bigger one, it is 0 to 1 for HDI, smaller one hai, and bigger one it is the PQLI, that is 0 to 100 hai. Now PQLI calculation is done by a simple average of all the three components. It is called as a arithmetic mean, while HDI calculation it is done by geometric mean. Geometric means once we have to calculate the indexes, each index like life is index and the education index and the income index, multiply them and just take a cube root. Now how to calculate the index? That is actual value of the country minus minimum value divided by maximum global value minus minimum global value. Okay, so each index you have to calculate. So try to remember the life expectancy index, because India ka the actual value is around 70 years or 69.7 years. The minimum global value is 20 years. The maximum global is 85 minus minimum. So this is about our life expectancy index. Then coming to what are the components of global hunger index is undernourished population, overall undernourished population, then underweight children of 0 to 5 year and under 5 mortality or the child mortality within 0 to 5 years. IMR is not a part of this. Okay? Then we are having the multidimensional poverty index also, which is including the education indicate dimensions, health and the living standards dimensions. Then coming to the indicators for health, the mortality indicators are very important, and the disability. Now here we are supposed to know the definitions, their importance. Now crude death rate is total deaths because of all the causes per 1000 mid-year population. Mid-year is what? It is 1st of July, it is mid-year. Okay? Then it is crude death rate. If you have to do an international comparison, we have to calculate the age specific death rate. It is what is called as the standardization. So we can be doing this is either by the direct method or the indirect method. When we are using the direct, when age specific death rate is available in that area, we are using the direct method. If a age specific death rate is not available, we are using the indirect method. Okay? And the indirect method we are calculating one ratio, that is standardized mortality ratio. What is an observed death divided by expected death into 100. That is standardized mortality ratio. So it should be ideally less than 100. If it is more than 100, it means it is unfavorable, means observed deaths are more than expected deaths in that particular area, and based on that some numericals can be there. Okay, and we'll be taking another separate YouTube live session for the numericals, and I had already shared you the flashcard of all the formulas and this definition of the rates and ratio at one place, and that is important from our examination point, because any of a small formula can be converted into a small numerical. Second is infant mortality rate, the 2 point to remember, that is infant death, that is 0 to 1 year death per 1000 live births, and it is a very good indicator of the health status of a country. Maternal mortality ratio, it is maternal deaths per 1 lakh live births. Okay? And it is an important component or the indicator of the availability and utilization of the maternal component only of the MCH care. यहाँ पे confuse नहीं करना. If a question is asked which is the best indicator of the whole MCH care, mother and the child health care, then your answer should be the perinatal mortality. But if they say that what is a best indicator of the maternal component of the MCH care, then it is your maternal mortality ratio. ठीक है? So दो questions से confuse नहीं करना. Positive mortality indicator is the life expectancy. The greater is the value, the better is the health status. Then we are having the disability indicators. Then DALI, disability adjusted life years, two components, the year which is the lived in the life because of the disability, or the year which has been lost because of the premature death, and 1 year lost is equal to 1 DALI. So they can be asking to calculate the DALI also, and this is a best indicator of burden of the disease. Okay? Now there are the other indicators of the burden of the disease also, so confuse nahi karna. Best indicator is the DALI, other indicators are the disease prevalence and the proportional mortality rate. Proportion में denominator है total deaths, not the total population, not the total cases. The total deaths because of the all causes, and out of that particularly because of that particular disease how many deaths are happening, that will be the proportional mortality rate of that particular disease. Okay? Then we are having the another indicator is that is quality adjusted life years, how many years the person has lived in a healthy state with or without the adjustment. And another question is that if any intervention we are doing and we are adding the number of the years in a healthy life in the lifespan, that is the quality is increased. So it is the measure of effectivity of the intervention if you are increasing the lifespan. Like suppose if you say that the new anti-cancerous drug are coming, or new anti-tuberculosis drugs are coming, new the HIV or the ART drugs are coming, which is increasing the healthy lifespan of a person by 5 years, 10 years, 15 years. So, this QALY duration is increased. So, this is a number of the years which are added by the intervention. It is the measure of effectiveness of the intervention, and it is indirectly affecting the QALY, not the DALY. Okay? And HELI means future में a baby is born, how long this baby is going to live in a healthy state with or without some adjustment. It is called as HELI. जो जहाँ पे भी E word है expectation, ये future में है for a small baby, और जहाँ पे भी QALY है Y years, that is already lived in the past. ठीक है? So QALY का mirror image है HELI. QALY means a person who is dying, then we look back how many years he lived in a healthy state. Now HELI, we just go in future. Okay, at the baby, that how long this baby will remain in a good health. Okay, and the best indicator of the disability, it is your HELI. So best indicator of the burden of the disease is DALY, but the best indicator of disability, it is HELI. Then coming to disease component, triad में epidemiological we are having agent, host and environment. If a time is added up, it become a tetrad or triangle. Now, this was an old model given by scientist John Snow, who was also called as father of modern epidemiology. But now as non-communicable diseases are coming up, so agent is replaced by the causative factors. In place of our environment, we are having the multiple factors which are affecting. Now, if we are trying to manage a disease, so we can reducing the new cases, the incidence and the prevalence duration of the disease, and this is what is called as a control phase. Elimination means that complete break in the chain of transmission, no new case but agent is persisting. Okay, agent is persisting, so always we have to put a barrier. So always continue all your control activities. In contrast to the eradication में the agent is also out, so there is no new case and no need to continue your activities because now there is no agent at all. Okay? So complete removal of the agent also, because of that the no new case is there, we can stop our activities, and because no agent is there, only the single disease has been eradicated as the smallpox, but two strains of the polio viruses are eradicated, P2 and P3, but still disease is happening with P1 strain. But elimination may, if you say that from India 6 diseases has been eliminated till now, that we had eliminated tuberculosis, leprosy, yaws, polio, neonatal tetanus and trachoma. The year not very commonly asked, if you can remember will be fine. Okay, and but this is very important that in future that what diseases has to be eliminated. Tuberculosis by 2025, we still the new goals has not come up. So till your exam, if any update is coming, this is only the answer, that tuberculosis is to be eliminated by 2025, measles and rubella by 2026, filariasis free India by 2027, and the leishmaniasis by 2027, and the malaria elimination is by 2030. Now यहाँ पे there is some confusion, don't worry. Now India declared that they had a last case of yaws in 2003 and they waited for 3 years, and in 2006 India has declared that now yaws is eliminated from them. But WHO validation happened in 2015, and 2015 mein WHO has given the certification that now India is no more having the yaws case. ठीक है, so India ने अपने आप में declare कर लिया था 2006 में, but WHO ने stamp लगाया in 2015 में. ठीक है. Now coming to the complications if you are not managing a disease. So here the question is asked that what is the sequence of the events. They can be giving you a clinical scenario and you have to ask in which stage. So be very careful and see what question they are trying to ask. So first is the stages. So Dance India dance competition in the hospital, like disease leading to impairment, causing the disability, ultimately leading to handicap. Now disease means disturbances at a cellular level, If it is causing the any loss of anatomical part or physiological psychological part of the body, it is impairment. अगर because of that there is loss of normal function, ठीक है, normal function क्या है, जो एक बच्चे का अगर function है 2 year plus, walking है, speaking है, listening है और hand से writing है, holding है, so अगर loss of the normal function for that age is gone, it is a disability. And if because of that the social function is lost, means now he is not able to do the job or he is not able to earn but support the family, then it is handicap. जरूरी नहीं है कि every disability will be leading to handicapped, ठीक है, but yes, the अगर handicap है तो there must be the disability, because of that that person has become handicapped, ठीक है. Then another is that every impairment is not causing the disability, ठीक है, like अगर appendectomy किया no disability, ठीक है, like hysterectomy किया in the postmenopausal no disability is there, but अगर आपने 25-year-old girl में अगर hysterectomy कर दिया तो loss of the function है, pregnancy नहीं होगा, वो disability है. So see the question very carefully. Now death certificate is written in the 4 line. The 1C is the most important line which is causing a main underlying cause. But remember the line 1A में ऐसा नहीं है कि the patient died because of cardiorespiratory arrest is the line 1. जो भी last diagnosis बनाई है हमने before the death of a patient, that is what is included in the line 1A. ठीक है, so this is 1A में है, then underlying cause, then main underlying cause is 1C. ठीक है, iceberg में the most dangerous part is this hidden portion which is including the submerged cases, is including the subclinical cases, the carriers or the undiagnosed cases, and it is the most dangerous part of the iceberg. ठीक है, so जो diseases में subclinical cases and carriers present हैं, and that disease will show the iceberg phenomena, and in those diseases where the subclinical cases and carriers are not present, it will not show the iceberg phenomena. So the question is asked, all are showing iceberg phenomena except, not showing except. So not showing याद कर लो, that will be better. Like rabies है, tetanus है, measles, pertussis, they don't show this iceberg phenomena. Now surveillance is active, means health worker is visiting house to find the cases, that is active surveillance. Multipurpose worker male is for malaria functions, malaria disease, and for other diseases like filariasis, leishmaniasis, leprosy and the tuberculosis, it is by the ASHA worker. Sentinel surveillance means from one patient we are trying to find out the contact of that particular patients also, and searching the disease in that, and it is commonly done in the sexually transmitted diseases. Now purpose is to identify the hidden cases or the missing cases, and we can report more and more of the cases, so it has to supplement the reported cases or notified cases. Now we are having the 11th edition of International Classification of the Disease, and which is having 26 chapters arranged in 3 volumes, and the few important chapters, if you could remember, is added is 26 chapter number for traditional medicines, then 21 chapter is given for unclassified unknown etiology diseases, the chapter 17 is for the sexual health, and chapter 6 is with the mental or psychological disorders. So this is about our topic of concept of health and disease. Now coming to the topic of epidemiology. Cholera is called as father of public health because John Snow, who is father of modern epidemiology, studied on the cholera epidemic, and after that he framed the concept of public health. What are the components in the frequency, incidence and prevalence? So this epidemiological tub is very important. Okay? So incidence is the new cases per 1000 population at risk per year. Okay? And what is the prevalence? Prevalence is the total cases. If it is counted in a particular period, it is called as period prevalence. If it is at particular point, it is the point prevalence. So it is the total cases per 100 population. Now prevalence is affected. This is a very commonly asked question. Prevalence depends upon the incidence. More is the incidence, more is the prevalence. Prevalence depends upon the duration of the disease or recovery. If recovery is quick, so duration is short, prevalence is reduced. Okay, and if the recovery is less, duration is more, prevalence increases. So if a duration of disease is more, the prevalence is more. It depends upon the death. If it is having a high fatality or case fatality or high mortality, suddenly dying, prevalence reduces. But if there is no deaths, then prevalence will be increasing. Okay? So remember these points. Incidence is calculated by the cohort study, prevalence is calculated by cross-sectional studies. Prevalence is usually expressed as per 100, but कभी-कभी question में per 1000 भी दिया होता है. So see the question carefully. Incidence is per 1000 population at risk. Now a clinical feature, special feature is incidence is called as a rate and prevalence is called a proportion, where the numerator is a part of denominator, but we are expressing as per 1000, it is called as a rate. If you are expressing as per 100, it is proportion. But if a numerator is not a part of denominator, we call this as a ratio when we are comparing the two different things like a sex ratio, maternal mortality ratio. Okay, and based on that they can be asking a small numerical as well as what will be changing in the incidence and the prevalence based on that particular activity. So look at that, whether the new cases are affected, look at whether the duration is changing, whether the recovery is happening shorter or recovery is delayed, death is happening quickly or the death is avoided, it will be affecting your incidence and prevalence. Then we are having the distribution in terms of time, place and person. The time is important and the epidemics different types. So if our cases are happening in the normal limits means our cases are within mean plus 2 SD value, it is endemic. But if it is beyond the mean plus 2 SD, it is called as epidemic. Even a single case of a new disease or eliminated or eradicated will be considered as an epidemic. If epidemic is happening in more than one country at a time, it is called as pandemic, and the few scattered cases what you called as sporadic. Now a type of epidemic depending upon how much time is required for a disease to become epidemic. Okay? If it is happening within hours to week, it is short term. If it is happening in more than 10 years or the decades, it is long term. And if it is repeatedly happening at an interval, it is called as periodical. Okay? Now short term could be a common source, single exposure or the point source like as food poisoning, Bhopal gas tragedy or any of a nuclear reactor gas release. Then sudden rise and sudden fall of the cases, all the cases are in the single incubation period. Okay? But if the cases are happening in a multiple incubation periods, multiple curves are seen, multiple peaks are seen, and this is called as a secondary waves. It is in common source, multiple exposure, and it is seen in a sex worker spreading the STD. They are sitting at one place every time the customers are coming, and so multiple exposures are there. But if there is a continuous exposure, so common source continuous exposure like water intake from an infected well or milkman transferring the infection, then there is sudden rise of the cases and then there is a long plateau and decline is there. Okay? But if there is a very gradual rise is there and a short peak and then decline, it is a person to person transmission or the propagative type, and it is seen in all waterborne infection or sexually transmitted disease. So confuse nahi karna. STD transmission, propagative. If it is transmission through the sex worker who is at a one place, so it is a fixed place, common source, but there is a multiple exposure is there. Now periodical could be seasonal depending upon the season or cyclical. No effect of the season, but at a certain interval the cases are repeated. Okay? So agar they say July mein rainy season mein malaria cases are more, it is seasonal. If they say winters mein because of fog the accident is more, or rainy season mein accident is more, it is your seasonal. But agar they say the weekend mein accidents are more, it is cyclical. Okay? Every year the influenza cases are more and is cyclical. Okay? So cyclical can be either because of the antigenic variation commonly seen in the influenza or change in the human behavior. Long term, very commonly asked question, it is what is called as secular trend. So secular trend means a long term epidemic and it is taking more than 10 years to become an epidemic. So this was your second component of epidemiology, that is the distribution of the disease. The third component is the determinants. This is by various studies we are trying to form an hypothesis and testing and confirming the hypothesis. So various epidemiological studies is that is observational studies or experimental studies. जहाँ पे भी groups होते हैं, so question is asked all are observational studies except, all are experimental studies except. ठीक है? So see the question carefully. So observational studies are maybe the descriptive or analytical. Descriptive means you have to describe a disease, that is hypothesis formation, like describing a disease in terms of time, place and person. Then we have to test the hypothesis by analytical studies, and 4 studies are there: the cohort, case control, cross sectional and ecological. And then we are having the confirmation of the hypothesis, and it is either by experimental or interventional studies, maybe the randomized or maybe non-randomized. Okay. So we should be very clear about that how we are conducting those studies, especially the analytical one. So case control study mein, as the name says, we are having the 2 groups. One is the cases where the disease is present, second group where the control where the disease is absent, or these are the healthy. So we are selecting from the community, and this is the start of the study when already the disease is present. Then we are just removing the known confounding error, and by doing the matching. Okay. And known confounding error, error is because of the confounders, and we know what the confounders are. These are the factors which are unequally distributed in the study group, and which has an effect on the outcome. So what we are doing, the matching, suppose here we are doing a matching for the age, we are doing a matching for the sex, we are doing a matching for the occupation, whatever the factors, if we find that they are affecting the result and they are unequal in the both the groups. So we are doing the matching for the known confounders between these 2 groups, the cases and control. Then we are going back and looking for the history of a risk factor. ठीक है, like यहाँ पे हमने एक study discuss किया था कि to see the relationship of smoking to the lung cancer. So we had a one group of our lung cancer cases, the second group is of the healthy individuals, and we had gone back to look for the history of the smoking, that in how many the smoking risk factor it is present in the lung cancer cases, and how many smoking history is present in the healthy individuals, and then we compare the odds of a risk factor in the cases and odds of risk factor in the control, and the parameter we will be calculating is the odds ratio. Then all are the advantages of this study, but only thing is that we cannot calculate the incidence. So that's why the preferred study is the cohort study. And how we do the study, when we conduct the study, this is the start point, we don't had the disease. Both groups are healthy without the disease. Then what is the difference? The first one is an exposed, means here the risk factor is present but no disease, and the second one is where the risk factor is absent. And what is my risk factor is the smoking. So the first group is the smoker, second is a non-smoker, and then we will be calling them at a certain interval, doing their regular follow-up like every yearly or 6 monthly depending upon the disease, and then we are looking for the outcome. And what is an outcome we are looking for is the lung cancer, whether the lung cancer developed in the smokers, in how many the lung cancer develops, and in the non-smokers how many lung cancer develops, and then we will compare the incidence in the exposed and the non-exposed and getting the parameter as relative risk. Okay? So the important point is that the direction of the study is forward, and when we have started the disease was absent. Okay? So all are the advantages of that over the case control, that we can calculate incidence, but the problem is that it is a very long study, which is an expensive study, and we have to expose the healthy person for the risk factor. We can lose our patient in the follow-up. So we are doing a combo of this case control and the cohort, that is what is called as a retrospective cohort study. Now please never confuse this retrospective cohort to your case control study. Now we are starting at this point, okay, that is 2025 suppose. Now if it is a case control, we are simply going back looking for the history, that's all. But what we are doing here is we are starting at this point, okay, but we are not going back or not taking the history, but we are going back to the point when they were absolutely fine, okay, absolutely fine, and then with the records we are making the 2 groups, like an exposed and non-exposed. How you can remember? Like suppose a patient is coming with the ultrasound report in the clinic, and patient says, doctor, I had been diagnosed as a gallstone or cholelithiasis and I want a surgery, okay. So you are having the report with you that patient is having the gallstone, okay, but you just go back and you ask them, okay, when you were absolutely fine? He says that I was absolutely fine 1 month back. Okay, 1 month back, say I had started having some uneasiness, the difficulty in the digestion of fatty food, and suddenly 3 days back I had a severe pain in abdomen, and because of that I got an ultrasound. So same is here, we go back to the point when they were absolutely healthy. Like the same study, we are looking for the lung cancer and we want to correlate its association with the smoking. So what we do, we go 10 years back, and from the hospital records we are collecting some of the smokers and the non-smokers, okay, and we know their phone number and addresses. Now we observe them, contact them, and we ask them whether they had any problem in this years, and if they had hospitalized, they had undergone the treatment. We analyze the records that those who were the smokers in 2015 without any lung problem, now what has happened to them today, and those who were non-smokers in 2015, what has happened to them today, and in that case we can be again able to calculate the incidence. So instead of going forward to waste time, we had gone back, and then with the analysis of the records we are coming to this point. Okay, so read the question very carefully and try to see the direction. So we are going back, but the final direction is, it is forwards only. Okay. Cross sectional and the ecological, these are the two studies which are done at point. Then the difference is, cross sectional mein we are individual person we are examining and collecting the information, so it is based on the primary data. But if the person information we are not collecting from that person, we are collecting from the another source, it is your ecological study. Okay, so this is how the 4 important studies, and you should be knowing how to conduct the study, because very commonly asked question in examination. Okay, now coming to this could be your image based questions. Now what are the parameters calculated is again a very important, from cohort, incidence, relative risk, attributable, population attributable risk, then odds ratio by the case control, prevalence is by cross sectional. The best study is the cohort, and cohort may be retrospective is better than prospective cohort study. Okay. Then another point is that what is the unit of the study? It is population is the unit of study in ecological, the rest may individual person we have to examine. Now coming to the identification, this we had already talked about. Then what are the advantages and disadvantages? Okay, again ask is, so advantage of the case control, short duration study, the less expensive hai, then no ethical risk is there, that no loss of the patient in follow up, that is no attrition. This is again a study of choice for rare disease is your case control. But if a question says study of choice for rare disease with expensive investigation, then it is your nested case control. ठीक है, while in the cohort में the it is disadvantage क्या है, जो advantage case control के हैं वो cohort के disadvantage है, long duration study है, then expensive study है, then there is the ethical risk because we are exposing the patient to the risk factor, then it is we are losing our patient, but still the number one or better over the case control by one parameter, that is incidence calculation is possible in the cohort, which is not possible in the case control study. Now we should be knowing the calculation of the parameters and the interpretation. The odds ratio is calculated by AD upon BC. With a given question, we should be able to fill the values in this 2/2 table. So first see how many are the cases having the disease. ठीक है, so disease patients आप enter करोगे, how many are healthy from the total population, then उसमें से भी in the disease how many risk factor is present and how many risk factor is absent. ठीक है, so that is A is the true positive, then C is false negative. Then in the healthy में in how many the risk factor is absent, that is true negative, and in how many disease is not present but is still the risk factor is present, so it is false positive. So it is AD, that is odds of the true situation. अगर disease है तो risk factor होना चाहिए and the disease is not present, so risk factor should be absent. By the false, false means no disease but risk factor present and the risk factor absent but still the disease is present. So true positive into true negative by false positive into false negative, and this is your odds ratio. And interpretation क्या है कि so much times higher history of the risk factor present in the diseased individuals in comparison to the healthy individuals. Then we should be knowing the formulas of these 4 parameters calculated by the cohort study. Like incidence is the new cases per thousand population at risk per year. Relative risk is also known as risk ratio, incidence in exposed by non-exposed. Then attributable risk is risk difference, that is incidence in exposed minus non-exposed by exposed, and population attributable risk is incidence total minus non-exposed divided by total. So, with a given parameter you should be able to calculate. Then interpretation, you should be knowing that relative risk means that so much times there is a higher risk of developing the disease in exposed in comparison to non-exposed, and it is used by clinician. Attributable risk means how much is the contribution of that risk factor in causation of that particular disease, and it is used by epidemiologist. Okay? And population attributable risk means that by removing that risk factor, how much reduction in the disease is possible in the population. So, it is used for making the policies. Now, for RR and the odds ratio, both are used to show the association between the disease and the risk factor. Then best is the RR. In all the both these, the baseline value is 1. अगर 1 RR या odds ratio है, so there is no association. More than 1 value है positive or risky association. Less than 1 है तो it is negative or protective association. Cross sectional study, prevalence study, because prevalence is calculated and it is based on the primary data. Ecological, based on the secondary data, and population is the unit of the study. Now, randomized control trial mein we are doing the randomization. So, how we conduct this study, just have a basic idea, like we have to check a new drug suppose. So, from the population, based on the selection criteria, we select the study population. And now at this point we do the randomization, and all these are the patients who are having the disease. Then we divide randomly into the 2 groups. One is with the disease, and here we are giving the new drug, this is called as an experimental. Second is with the disease, but here we are giving the either the placebo, B complex, or the old existing drug, this is our control, and then we do the analysis, and after that we do the crossover. Crossover means those who were the control, now we are making them experimental, and those who were experimental, now we are making them control, and then we do the analysis. Okay? So, finally what result we are getting is the effect of the drug. Now, how we differentiate it from the cohort study, prospective cohort, when this is also a forward study, but what is the difference is that in this we are having the first group as the patients which are on the treatment, and the second group is patients without the treatment or the control group. What was the groups in the cohort study? This was the exposed group, healthy with risk factor. यहाँ पे disease with the drug, okay, and यहाँ पे non-exposed थे means healthy without the risk factor. यहाँ पे है disease with the no drug or with the old drug or with the placebo drug. ठीक है? So this is the basic difference in RCT and your a cohort study in a diagrammatic representation. Then coming to the randomization ka, the very commonly asked question is what is the advantage of the randomization? It is done to remove the selection error as well as it is removing the confounding error. So, the 2 more questions, which is the best method to remove the confounding error, it is randomization, because it is removing both known and unknown. But if a question is asked which is the best method to remove the known confounding error, it is the matching, and that is the most commonly used method or the simplest method for correcting the confounding error. Okay. Then we are having the other type of errors also, which is because of the person who are in the study. It is called as systemic errors or the bias. Because of doing a study on a small sample, it is a sample error. Okay. So, sample error cannot be completely removed, but it can be decreased by taking a bigger sample size. But yes, systemic error we can be corrected. Now, it could be because of the subject. And subjective error, it is corrected by doing a single blinding. We are not informing the patient, okay? And it can be either the recall error, it can be the anxiety related error, or by changing the behavior of a person, that is called as a Hawthorne error or attention error, okay? Now we are doing a single blinding to correct this subjective error. Then there is a investigator error. So interviewer error, because of the difference time is given in the interrogation, this is corrected by double blinding. So double blinding is correcting the interviewer error as well as the subjective error, and the selection error, it is corrected by randomization. Then we are having the analyzer error. It is corrected by the triple blinding. So triple blinding is correcting analyzer, interviewer as well as the subjective error. So the most commonly used blinding is the double blinding, but the best is obviously is the triple blinding. Okay. Now confounders may, the 3-4 questions, what are the confounders? These are the factors which are unequally distributed in the study and control group, but they had its own effect on outcome. Okay. Then how we can be correcting, we had already discussed by randomization or matching. Okay. So blinding we had already talked about. Barkesonian error is a type of selection error, because if you are going to a cancer hospital, you find all cancer patients and its prevalence is very high. Now clinical phases, the phase 1 we are doing on the healthy patients, healthy persons, the patients may 2, 3 and 4. The longest phase is phase 4. The post marketing phase is phase 4. The drug is launched in the market at the end of the phase 3. The maximum drug failure, it is seen in the phase 2. Okay. Now nested case control study, the 2 points, it is a type of cohort study, and it is indicated when the rare disease with expensive investigations, and these are some miscellaneous points. Then a study with the attrition, loss of patients in the follow-up, that is a prospective cohort and RCT. The best study for the natural disease course, prospective cohort. Framingham Heart study, it is a famous cohort study. Nested case controls, a type of cohort study. The first step of epidemiological investigation is a disease confirmation, and if an epidemic is there, so we have to continue the epidemic and studies till the twice of incubation period of the disease from the last case. The best epidemiological study is meta-analysis, but your answer should depend upon the choices, and this is what is an evidence based pyramid depending upon the ranking, that number 1 is a meta-analysis, systematic review, RCT, then retrospective cohort, prospective, like this. So your answer should be depending upon the choices. The best analytical, don't confuse, best analytical study, it is your retrospective cohort study is the best analytical. If retrospective is not in your choice, you can go with the prospective cohort also. Okay. So confuse nahi karna. Agar best epidemiological study hai, then your answer should be the meta-analysis. If it is not in your choice, systematic review. If it is not in your choice, you can go with RCT. But agar question hai best analytical study, then choices are RCT and retrospective cohort, then RCT is not an analytical, it is your experimental. Okay. So in that case, the answer should go as analytical study is retrospective cohort study. Okay. So be very careful about this. Then causality criteria is Surgeon General criteria or the Hills criteria. The best criteria is the temporality, means first risk factor, then the disease should appear, and it is best studied by prospective cohort study. Okay. Association and causation. Association means two factors are present together, and if it is direct relationship, maybe a one factor to the disease, multiple factor to the disease, it is a direct. If it is in the presence of the third factor, that is indirect, like high altitude पर hypothyroid है, ठीक है, but altitude is not connected because high altitude पर low goiter है, low iodine है, because of that there is a goiter in the high altitude. And false is spurious association, and ऐसा लग रहा है कि वहाँ पे ज़्यादा है लेकिन वो false है, like a high deaths is happening in the cardiac ICUs or in tertiary level hospitals, ICUs, nurseries, labor room, because high risk cases are going. It is not like कि services are not given there. Okay, so it is looking like as a false, so spurious association. So this is all about our the epidemiology. Yes, one more point is lead time bias. Lead time, we know it is the time interval between the first possible diagnosis and appearance of the disease symptoms, and if you are early detecting the disease, and it is giving us a false impression of increase in the survival duration. Okay. So apparently looking the increased survival rate because of early detection of the disease by screening, that is what is called as a lead time bias. So this is all about our this topic of epidemiology. Screening, if we say the type of the screening, prescriptive for the benefit of individual, it is a secondary level prevention. If it is for the benefit of others, prospective. So, it is both primary and the secondary, but the single best answer is primary level prevention. High risk screening, cost effective. Multi-purpose, more than one disease detected at a time, like antenatal screening for the diseases which can be transferred to the baby, or multiphasic means more than one test for a single disease. Okay? Now, a lead time we already talked about, time interval between the first possible diagnosis and usual time of appearance of the clinical symptoms. Sensitivity is true positivity, means ability of the test to correctly detect a disease, and specificity is the true negativity, means ability of the test to correctly exclude the disease. So, again we should be able to fill the values in this table, and given question may try to find out if they are giving you the total cases and the disease prevalence. Okay? So, disease prevalence ke base pe you have to find out how many are the disease cases. So, A plus C will be your disease cases and remaining will be healthy. The next is, in contrast to the odds ratio, the same table we are using there also, but वहाँ पे there was a risk factor था, यहाँ पे है test result. Then you see that out of these disease, how many are declared as positive by the test and how many are declared as negative, although they had a disease means false negative. Then out of the healthy, in how many the test is negative and how many the test is positive. Sometimes they can be giving you the total test positive also, and then they say that this is having the disease. So, might be they are giving a plus B value, or they are saying the total healthy or test negative as C plus D value. So, see in the question, you fill the values, and you know the formulas for 4 parameters. So, sensitivity is A upon A plus C, or true positive upon opposite true positive plus false negative. Specificity, numerator is true negative, opposite true negative plus false positive. All positive, numerator true positive by true positive plus false positive, it is your positive predictive value, and all negative, it is your negative predictive value. Okay, so 4 parameters, the 4 values and calculations. Now, positive predictive value, what it is defined as, वैसे पूछते नहीं है, presence of the disease in the test positive individuals and absence of the disease in test negative individual is negative predictive value. But yes, they ask is its connection or a different relationship, very commonly asked. Now, prevalence and predictive value. If prevalence increases, positive predictive value increases. So, positive predictive value is directly proportional to the prevalence, but it is inversely proportional to the prevalence. Okay? So, prevalence increases, negative predictive value decreases. Then, most important quality of the screening test is sensitivity. The usefulness of the screening test is again sensitivity. Highly screening test, sensitive test is used as a screening. Now, if we are getting a high false positive cases in a study, it could be any one of the reason. Either the test what you are using is highly sensitive or the disease prevalence is low in that area. But if a same test is used in a different areas and still we are having the more false positive in one community, it means the disease prevalence is low, because now the sensitivity will not affect, because same test we are using. So, sensitivity and specificity are always the constant parameter, it is not affected. So, agar same test we are using in a 2 different, then only the disease prevalence is changing the false positive values. But high false positive in any situation, we can be either because of the low prevalence or because of the high test sensitivity. The diagnostic power of a test depends upon all the 3 parameters: sensitivity, specificity and the disease prevalence. Okay? Now, if you apply the test in the series, means first test all positive, we applied the second test. The purpose is the result ka we want to increase the specificity as well as we want to increase the positive predictive value. Okay? And the rest 2 parameters decreases. And if you apply the test in parallel means more than one test at a time, so opposite of the series. So, try to remember for the series only. Okay? Like with the HIV, ELISA and Western blot. Okay? ELISA positive, we apply the Western blot. Purpose is, if you are healthy, you should be declared as negative, and if you are having a disease, you should be declared as positive. Okay? So, अगर आपका इस केस में if you apply the test in the series, purpose is if every positive should be having the disease, means 100% positive predictive value should be there. If we want to make test highly specific, we have to shift the cutoff to the upper side, higher side. If you want to make a test highly sensitive, we have to shift the cutoff towards the lower side. Okay? Then दिस कुड बी योर इमेज बेस्ड क्वेश्चन. अगर आपको व्हाइट पैच मिल रहा है, इट इज वाया टेस्ट. अगर आपको पर्पलिश वी कैन से द color है over the cervix, it is your Willi test. ठीक है. Then chemical we are using is the lugolcidine and यहाँ पे जो chemical use करते हैं acetic acid है. Now please listen carefully. Now white patch, it is suspicious. In via we refer the patient to higher center. Now here if a purplish brown color is appearing, it is healthy. Now if you are having a colorless patch or the turmeric yellow color, it is unhealthy. So white patch is suspicious in via, but a colorless patch, it is suspicious in villi. Okay, so confuse nahi karna. Now cost effective test for cancer cervix, via and villi. The best answer is via because it can be performed at the PSC without the cytology reporting, without the microscope or without the requirement of a cytologist. But the best screening test for the cancer cervix is Psm1. Okay, but confirmation is always by colposcopy guided biopsy. If you talk about the breast cancer, the cost effective is self breast examination once in a month post menstrual, but best screening test more than 40 years mammography, less than 40 years MRI, if not available then ultrasound. Okay, so this is all about our this topic of screening. Now one more point is Kaplan-Meier curve, it is used for survival analysis, and ROC receiver operator curve, it is drawn between true positive and false positive. Yes, one more point is the validity or accuracy means the result we are getting closer to the actual value, that means the test is valid or accurate. Repeatability or precision, every time we are getting the same value, that is what is precision. ठीक है ना, precise जैसे means also कहते हैं shooting should be precise and accurate, means center goal पे भी लगना चाहिए and every time it should be there only. So same value every time it is precise and nearer to the correct value it is accurate. Again very important topic is demography and contraception. Demographic process is not affected by morbidity because यहाँ पे head count remains the same while social mobility is affecting. Now we are having the two group of the indicators, vital and population, very important. So vital indicators are जहाँ पे life and death is affected. So crude birth rate, the total live births per 1000 immediate population, crude death rate, total deaths per 1000 immediate population, but four are the important: GFR, TFR, GRR, NRR. General fertility rate is the total live births per 1000 reproductive female immediate population, that is of 15 to 49 years. Then total number of the children born alive to a lady in her entire reproduction is TFR. Then total number of the girl children born alive to a lady in an entire reproduction is the GRR, G for girl, T for total. And out of these girl children remaining alive till their own reproduction is NRR. So only one factor which is affected by the mortality after birth is NRR, and that is the most important demographic vital indicator. Now to the current values, now this is the latest update of our SRS value. SRS we can say the data released for SRS September 2025 survey, and it is saying that current crude birth rate of India, it is 18.4, the death rate is 6.4, and the TFR of India, it is 1.9. Okay, they can be giving you the obstetric history like this, and they can ask us to calculate the TFR, GRR or NRR. Now what is the growth rate? Remember, it is a birth rate minus death rate, but always divide by 10 because it is in percentage. Okay, so current India का जो growth rate है, it is because 18.4 is the birth rate, 6.4 is the death rate. So current हमारा जो growth rate है, it is 1.2%, and because of that our doubling time is, it is 47 to 70 years. So see the question carefully. If they're trying to ask the doubling time in as per the 2011 census, because 2011 census में हमारा growth rate था 1.64% and doubling time we see 35 to 47 years. But if they ask what is the current doubling time, because current growth rate is 1.2%, the current doubling time is 47 to 70 years. Then the goal for NRR is to achieve, and this is for population stabilization. For that, the TFR should be 2.1 and couple protection rate should be more than 60%. The eligible couple register is maintained at the sub-center by multipurpose worker female. And what is the couple protection rate means percentage of the eligible couple who are using contraceptives. And who are the eligible couple? Where the age of the wife is between 15 to 49, means in the reproductive age. Then population indicator. So based on that we should be knowing the definition, and they can ask a small numerical. So sex ratio, if it is simply mentioned, sex ratio means at birth female per 1000 male. ठीक है, remember it is not male per female, female per 1000 male. Literacy rate में literate per 100 population of 7 years and more. So denominator is 7 years and more. Then dependency ratio. Dependency ratio is non-working to working. So age group of a working is 15 to 65 years and non-working is less than 15 years and more than 65 years. So be very careful in the given question and read the question carefully. Try to identify which is the non-working and which is the working population. Then demographic transition or the cycle is again a very important and could be an image based question. They can be pointing an arrow on this line, red line, it is your birth rate, then a black line, it is a death rate, and this is your population size, and the gap between the birth and the death rate, it is called as a demographic gap. Okay. So what happens in the phase 1? High stationary, birth and death is high, so population stationary and demographic gap is constant. Now phase 2, birth rate is very high, the death starts declining with the medical services, so there is increase in the demographic gap starts at the beginning of the phase 2, maximum at the end of the phase 2, and population increasing very fast. It is early expansion. Then birth rate is also reduced with contraception. The death continues to reduce, so demographic gap constrict. Okay, but still birth rate is more than the death rate, so population is increasing at a slower rate. This is the stage 3. Late expansion. India is in this phase of the demographic cycle. Then coming to the low stationary, the birth rate is low, death rate is low, population stationary, demographic gap constant. Then the reversal, the birth rate is 0 but death is happening, so population is reducing. Okay, so this is the reversal phase. So these are the 5 phases. We should be knowing in each phase what happens to the birth rate, death rate, demographic gap and population size. Then coming to the data collection, every 10 years it is the census, and under the Ministry of Home Affairs, the next census is due in 2027, 00R of 1st of March we will be calculating. Then it will be our 16th census, because last we had done the 15th census in 2011. Then every 5 years we are, yes, one more point is that if you are counting the individual based on where they were present on the day of counting, it is called as a de facto, and based on their permanent address, if you are counting, it is a de jure. So this is preferred. Okay. Then every 5 years we are doing a National Family Health Survey. Till now the 5th round has been completed, but the data has been released only of the 5th round. Okay. And it is under the control of Ministry of Health and Family Welfare. Confused nahi karna. Census was under the Ministry of Home Affairs, and it is under the Ministry of Health and Family Welfare. Then every 6 months we are conducting survey, that is Sample Registration System, SRS survey. It is known as the dual survey. Means 2 activities. One is continuous reporting of the birth and the death, and every 6 months a survey by independent officer. Another question, continuously reporting of birth, death and marriage, it is coming under the civil registration system. Within 3 weeks we have to register birth and deaths, and within 2 months we have to register a marriage in that particular area. And If it is a home delivery or death in the village, it is the responsibility of the ASHA worker to report to the Gram Panchayat and the sub center about the birth and the death happening in that particular area. Then coming to population pyramid, the three features by the pyramid. It is a presentation method is a histogram. One side double histogram, rather we can say male population and female. The base is representing the fertility. Broader base means high fertility for the developing countries, and height is representing the lifespan. If higher lifespan, it means a high life expectancy, and the symmetry, it is representing the sex ratio. So, developing countries may broader base and the narrow tip because of the high birth, but in the developed countries birth is less. So, it is now the spindle shade, means a narrow base, there is a bulge in middle, and then it is going towards the top. Now, coming to the contraception, it could be the temporary and permanent. It can be conventional or emergency. Convention means they are using during act or before act. Emergency means after the act. Both are primary level prevention because to prevent the pregnancy. Who we are targeting to use the contraceptives? They are the target couples. Okay. Now, earlier there was a different definition for the target, so no confusion. Now we say every eligible couple is the target couple. Means every couple with a wife of age group of 15 to 49 years should be targeted for use of contraceptives. So, now every eligible couple is the target couple. Then this is important logo, inverted triangle with husband, wife and the baby, that is for National Family Welfare Program. Under this, home delivery of contraceptive by ASHA workers. The counseling method in contraception is the gather approach. And spike method of counseling is when we want to break our news for some bed disease or the cancer prognosis. Okay. Then three words, निश्चय is the urine pregnancy test kit. निकुष्य, शय कहते हैं tuberculosis को. So it is a TB software. And निकुष्ट, कुष्ट कहते हैं leprosy को. So this is a leprosy software. निश्चय हिंदी word है decide करना. ठीक है. So it is for the urine pregnancy test kit. Now, PP-IUCD, just after the delivery, we are putting IUCD for birth spacing to be inserted within first 48 hours after delivery of baby and placenta. Mainly it is for the birth spacing and preferring is the Copper-T 380A, which is available free of the cost at government centers. Non-hormonal oral tablet is Chaya, available in the market by the brand name of Saheli, and safely can be given in lactation. Because जो hormonal tablet है, OCPs, Malayan cannot be given in lactation, and there is a quick return of the fertility once patient stops. Within 3 to 6 months she can conceive. It's also marketed as once a week pill, but initially for 3 months twice a week, and then once a week we have to give. Then these Chaya tablets can lead to amenorrhea. So remember, other contraceptives which are causing amenorrhea because of thinning of endometrium is Chaya tablet, Mirena injection, DMP injection, Mirena implant, sorry, DMP injection and the Norplans. They all are causing the amenorrhea. Okay? So Mirena, it is a hormonal IUCD. Hormonal injection name given is Antura. Now, gap is a gap between knowledge, attitude and practice. It is in contraception. Okay? Then Mission Parivar Vikas means those districts where we had a high TFR, we are motivating more for use of contraceptives. Criteria for undergoing the family planning surgery, at least one baby of more than 1 year. Incentive, just correct it. Now for vasectomy, we are giving 1100. For all the type of tubectomies, maybe a mini or laparotomy or we can say the laparoscopy, we are giving 600 rupees. Okay? And patient ko jo who are motivators, we are also giving this 200 and 150 in vasectomy or tubectomy. But Mission Parivar Vikas mein we are giving a little more amount. Okay? So don't confuse yourself. You can remember this amount, this value if you can. Then coming to natural methods, it is only to identify the time of ovulation and take a precaution. But barrier methods, the 3-4 points. It is preferred method for young adolescents. The non-contraceptive benefits is STD prevention, High failure, so used with spermicidal gel having content as non-oxynol 9. Okay. Then sponges are already incorporated with non-oxynol 9 available in the market as today tablets. IUCDs, second generation copper IUCDs are commonly preferred, preventing the fertilization. Now these image based questions are very important. If it is T-like structure and copper on both the arms, it is with the thread, so it is an IUCD, so it is your copper T380A. If it is thread on a vertical arm with the shape according to the uterine cavity, it is your multi-load. Then if it is T-like structure but no copper, you could see, but there is a bulge in the vertical arm showing a capsule containing hormone. So this is your hormonal IUCD, Mirana, brand name or LNG20. Okay, and this is old inert devices, plastic ring tha, loop like structure, so this was Lippi's loop. Very commonly they ask is which is the preferred time and the best time. The preferred time is postpartum PPIUCD within 48 hours of the delivery, but the best is pregnancy should be excluded, post-menstrual or post-abortion, just after abortion of the first trimester you can put the device, or after the 6 weeks of puerperia. Okay? And shelf life, copper T380A lasting for 10 years, Mirana, be very careful, Park says 7 to 10 years, if it is not in your choice you can go with 5 years. Okay? And multi-load 375, it is for 5 years. Now best method of the contraceptive for birth spacing. Now very commonly they ask is contraindication, the absolute and relative. The first very important is PID, presence of infection, no foreign body, undiagnosed bleeding or suspected pregnancies. And again the little bit different from Park says the history of ectopic as absolute, but all other literature says it is relative, so I had put in a relative contraindication. Side effects, the most common side effect is menstrual irregularity. You have to wait for 3 months for body to adjust, and only the iron folic acid, tranexamic acid and reassurance. So don't jump for removal. So they will be giving you a clinical scenario and they can ask what has to be done next. But if a patient is coming with pain because of underlying infection, immediate removal and give the antibiotic. Now, if there is a pregnancy with IUCD, then the question is removal. So, remove can be simply by pulling the thread. Okay? And don't put hysteroscope if a patient is pregnant, because soft hoga, you can perforate. Ectopic, treat accordingly. Perforation, if it is outside the uterus, removal by laparoscope. If it is displaced within the uterus, removal via hysteroscopy. Hormonal method mein, the oral is important, maybe a combined or progesterone only. The very commonly asked question which is given in lactation, it is progesterone only pills. Combined pills are contraindicated. Okay? Market mein Mala N is the national supply, free of the cost. Now it is a 21 plus 7 tablet pack. 21 is hormonal tablets, white color, and each is containing 30 microgram of ethinyl estradiol and 150 microgram of levonorgestrel. And each of our iron tablet, it is containing the 19.5 milligram of elemental iron. Don't confuse the normal adult iron folic acid tablet what we are using in pregnancy and lactation is having 60 milligram of elemental iron. यहाँ पे 60 milligram salt है and elemental iron 90 milligram है. और अगर salt की बात करें ferrous fumarate की in adult, so that is around the 200 milligram of the ferrous fumarate. ठीक है, 200 milligram of ferrous fumarate salt है and 60 milligram elemental iron है. जो माला एन में टैबलेट है आयरन का, उसमें 19.5 milligram elemental iron है, 60 milligram salt है. ठीक है, obviously to be started post menstrual, and if a patient is missing the one tablet, next day take the missed tablets, means maximum 2 tablet patient can take on the next day. But अगर 2 या more tablet are missed depending upon the week, 4 rows हैं 4 week के लिए, missing any tablet in the first and the second week, important is backup contraceptive for 7 days, and if she had a sexual relationship within the past 72 hours, emergency contraceptive to be given. If she is missing in the 3rd week, in that case, once hormonal pills are finished, throw away the iron tablets and start the next pack. So patient will not have any withdrawal in that. Backup may or may not be used, and again throw away the iron tablets and restart the next pack. Fourth week में अगर है, that is iron tablets are missed, nothing has to be done. Whatever the number of the tablets are missed, you can just discard and continue the pack. ठीक है. Ovulation inhibition mechanism of action, very commonly asked is cancers increase or decreased. Increases breast, cervix and hepatocellular adenoma of liver benign, and decreases uterus, ovary and colorectal. ठीक है. Contraindication, the very important contraindication is the deep vein thrombosis, absolute. Other liver disease, cardiovascular diseases or family history of the breast cancer. But relative is 40 plus non-smoker, 35 plus is smoker, presence of migraine or if she is lactating, and especially in the first 6 months when absolute means exclusive breastfeed is there, or presence of diabetes or hypertension to be avoided. Looking for side effect if everything was normal before. So, it is deep vein thrombosis, cancers are increased, breast, cervix and hepatocellular adenomas, weight gain could be there, migraine could be there and vaginal candidiasis is seen. Best method to delay the pregnancy in or the first pregnancy in recently married couples. ठीक है. So, this is your pack. अगर all 28 tablets are of a same shape size, it is a progesterone only pills, and if it is 21 tablets of one color and 7 iron, it is your combined pills, OCPs. ठीक है. Combined oral contraceptive pills. Then hormonal में मिराना में इमेज एक तो याद रखनी है, दूसरा डेली रिलीजेस 20 माइक्रोग्राम ऑफ LNG, levonorgestrel and duration is 7 years to 10 years or if it is not in your choice 5 years. Injection में commonly we are using the DMPA that is given the name as Antura, frequency every 3 months, intramuscular and it is containing 150 milligram of DMPA per ml. ठीक है. Then it is causing amenorrhea, no doubt about that, and the delay in the return of fertility, that is takes 6 to 12 months. Okay, so be very careful practically. When the patient wants the next pregnancy, try to stop at least 12 months before. Now implants, normally we are preferring as one rod implant, which is also called as Implanon or Nexplanon. Nexplanon is having the barium sulfate also and it is lasting for 3 years. अगर 6 rod है, Norplant 6, it is lasting for 5 years, 2 rod hai, it is lasting for 3 years, but now it is preferred, that is single rod. Skin patches, not very important. Permanent method, very important question. The advice after vasectomy that 3-month additional barrier methods and cost effective method is there. Okay? Always send the piece for histopathology and it is protecting you against medical legal litigations. Now, very commonly asked question is in the surgical, just after the delivery, which method you will be preferring for tubectomy? It is mini laparotomy. Okay? So, just after the delivery, postpartum method mein mini laparotomy is preferred, laparoscopy is contraindicated. Okay? And why? Because big uterus and agar aap laparoscopy karoge through the umbilicus, you may perforate the uterus. The method what we are using is modified Pomeroy's, double ligature, 2 threads or 2 ties are there, absorbable suture and this is a catgut. So, after absorption the ends will be separated, so recanalization possibility is reduced and just after the delivery if you are doing at the cesarean section you can do it at same time. लेकिन अगर vaginal delivery के बात कर रहे हो तो let the patient settle for 24 hours and there should not be any PPH and we will be doing within the next 7 days. So, from 24 hours delivery till 7 days of the delivery we are doing this if it is a vaginal one and the site of the tube which is ligated is isthmus. अगर आप laparoscopy कर रहे हैं, so again the site is ligated as stomach but most commonly we are using the Fallop ring in our program. Can be using the Hulka's clip but ये expensive होते हैं and Fallop rings we are commonly using in laparoscopy. So, this is blocking the tube like this and this is Hulka's clip is there. Okay. Non-surgical method we can be by Assure implant. So, this is a titanium implant hai. Hysteroscopically we are inserting in both the cornal ends of the tube. So, remember if patient is undergoing the mini laparotomy or the laparoscopic ligation then no post-operative contraceptives barrier methods we are requiring for the 3 months, just like as not like as vasectomy. But if patient is undergoing the Assure implant, because it is causing fibrosis and blockage of these tubes, and this is taking 3-month time for blockage of the femoral lens or the cornal lens of this tube. So we are advising the couple to undergo a use of barrier methods for the 3 months. So barrier methods for 3 months if a patient has a Assure implant, female patient, or the male had undergone the vasectomy. But if female had undergone the tubectomy with the mini laparotomy or laparoscopy, then it is not required. Now emergency contraceptives, yes, the best is the IUCD, which can be used till 5 days, but preferred is LNG tablet, keeping the privacy, and it is used up to 72 hours. If nothing is available, then अगर माला N tablet है or any of our OCP is available, अगर estrogen उसमें less than 50 microgram है, like Mala N में it is 30 microgram. So 4 tablets stat, repeat 4 tablet after 12 hours of the first dose, and these total 8 tablets to be taken within 72 hours. लेकिन अगर any combination of the pill which is estrogen of more than 50 microgram है, then 2 stat, then 2 after 12 hours of the first dose, total 4 tablets to be taken within 72 hours. Now efficacy can be assessed by Pearl Index and Life Table. The best is Life Table, but exam में Pearl Index is asked. And यहाँ पे we are doing an analysis of the 1200 month use. That is important. So Pearl Index is used for contraceptive efficacy. How we define accidental pregnancies per 100 women years. 100 women years means menstrual months in a year is 12. So 100 menstrual years. So 100 into 12. So 1200 month of exposure we are using. And how to calculate Pearl Index with the given numerical accidental pregnancies divided by the total month of exposure. This is important. And total months के लिए how many women are using, how many years, and multiply by 12 to convert this year into months. That's all. Into multiplying factor is very important. It is 1200. Okay. And try to remember Pearl Index of the commonly used methods, okay, because they are having a very low Pearl Index and high success rate. जितना Pearl Index कम होगा उतना success rate ज़्यादा है. The lower is the Pearl Index, the higher will be the success rate. ठीक है. Long acting, reversible and non-reversible. ठीक है. So read the question very carefully, and it is hormonal or non-hormonal. ठीक है. Non-acting, long-acting, non-reversible will be tubectomy and vasectomy. But reversal means once you stop, patient can have pregnancy. And इसमें non-hormonal जो है, we are having copper T or multi-load, and hormonal जो है, we had IUCD, Mirena, DMP injection or implants है. ठीक है. And contraceptive of choice we already discussed. ठीक है. So this is all about our this topic. And now one more point is that selection of the contraceptive is based on this medical eligibility criteria. Okay. So criteria 1 and 2, if they are fulfilling, it can be used. Then 3 and 4 are avoided. Okay. So if they are fulfilling the criteria of 1 and 2, we have to see for the age, parity and gravida, whether breastfeeding or not, and we are getting this numbering. If 1 or 2 is coming, then that method is used. Like it is coming as 1 for implant, we can give the implant. 1 for the POPs, we can give the POP. 1 for the COCs, we can give the COCs. And 2 is for the DMPA. So we can be giving, but अगर 3-4 आएगा तो नहीं दे सकते. ठीक है. So this is a wheel है, medical eligibility criteria wheel. ठीक है. So this is what medical eligibility criteria wheel है. ठीक है. 1 में we can use, the 2 also we can be used, the 3 and 4 are usually avoided. Now coming to the next is our healthcare system of India. The question is, what are the elements of the primary health care? Elements, 8 components you can remember as element, because question is asked, all are the elements of primary health care except. Okay? So element is the health education, E for health education, then locally endemic disease prevention and control, then availability of the essential drugs, MCH care, immunization, nutrition, the treatment of common diseases, and safe water supply and sanitation. Now, what are the principles? There should be the equitable distribution, community participation, intersectoral coordination, and appropriate technology. Now, level of healthcare, again it is important. The centers which are providing the primary level care are the village staff, sub-centers, and primary health centers in both an urban and rural areas. And we already discussed that the centers which are giving a primary level care now called as Ayushman Arogya Mandirs. Okay? Second level care is given through the community health centers, sub-district hospital and the district hospitals, and the tertiary level care is given through medical college and super specialty hospitals. Now, please be very careful. The second level care centers are also known as first referral units, which are providing the second level care, and the tertiary level care centers are called as second referral units. But questions are commonly asked from the first referral units. So, what should be the basic services available at the FRUs? They should be able to perform the emergency services related to obstetric, means the cesarean section should be able to perform, okay? And there should be the emergency care of the sick newborn baby, okay? Because आप obstetric के लिए you are doing a cesarean, so baby may be hypoxic, meconium stained, distressed, so you should be able to take care of a sick baby. So we are having the pediatrician for the care of the baby, we are having the anesthetist to give the anesthesia, we are having an obstetrician to perform the cesarean section. Okay? So, obstetric care should be there, emergency surgical intervention should be there, the emergency care of the sick newborn, and if you are doing a surgery, then blood storage facility should be there, and essential lab services. Okay? And if needed, then ambulance should be there, so we can be referring or transporting the patient to the higher centers. Okay? Then we are having the special population coverage till community health center, because district ke liye there is a one hospital in the whole district, maybe a small district or bigger district. Now we should be knowing the population coverage of the sub centers, PR mini health centers, community health centers in the plain area or in hilly area. If nothing has been mentioned, go with plain. If actual value not given, go with range, nearest value. So, sub-center 5,000 or 3,000 as plain or hilly, PSC 30 and 20,000, and community health center 1.2 lakh and 80,000. If we talk about the beds, the 30 beds at community health center. Now, PSC is type A and type B depending upon workload, and that is deliveries per month. Now, if there is the less than 20 deliveries per month, these are called as type A PSCs. Agar more than 20 or more than 20 deliveries per month, it is called as a type B PSC. In both, we are having the 6 beds. Then type A subcenter not able to conduct the deliveries, so these are non-MCS centers because beds are absent, and type B subcenters beds are present, minimum 2 beds are there, so these are called as MCS centers are there. Now, which staff is posted is important. At subcenter, we are having multi-purpose workers, male and female, and community health officer. Now, this has been added up. Community health officer, it is either the Ayush doctor or it is a trained staff nurse. ठीक है, जो GNM nursing course करके आती है ना, that is trained staff nurse will be there. At PSC, we are having the medical officer, means post MBBS doctor is medical officer. The lowest posting is at the PSC, and health assistants. Other staff is also there. Then specialist, means the post PG doctors are present at community health centers. Okay? Then village workers, grassroots level workers, the 2 workers are important, and ASHA workers and Anganwadi workers. Okay? ASHA workers accredited social health activist. They are in the rural areas, part of National Rural Health Mission earlier, and in 2013 they had an urban component, urban health mission. Both are clubbed together in 2013 as National Health Mission, and now it is called as Pradhan Mantri Samagra Swasth Mission. ठीक है? So अगर question पूछा जाता है कि ASHA is a part of which program, so first answer should be Rural Health Mission. If it is not in your choice, then you can go with the Pradhan Mantri Samagra Swasth Mission. If it is not given, then you can go with the National Health Mission. ठीक है? So ASHA अगर कहें तो first option should be that is the National Rural Health Mission. If it is not in your choice, you can go with Pradhan Mantri Samagra Swasthya Mission. If it is not in your choice, you can go with National Health Mission. Okay? So, ASHA population coverage is, it is 1 per 1000 population. Okay? It is 1 per 1000 population. Remember, proposed is 1 per 2000, but till your exam answer should be 1 per 1000. Anganwadi workers, at least remember for the plain areas, and it is 1 per 400 to 800. Okay? Then TBS and village health guide, not very important. The recruitment criteria, 10th pass, if it is not there, 8th pass for ASHA, 12th pass for Anganwadi workers, 4-month training for Anganwadis, 23 days training for ASHA workers. ASHA is working from home, but Anganwadi workers, they are working from centers, ICDS centers are there. Anganwadi workers are trained through the Child Development Project Officer. One Child Development Project Officer is training the 4 Mukhya Sevikas. Each Mukhya Sevika is training 25 Anganwadi. So, indirectly, one Child Development Project Officer is training 100 Anganwadis. ASHA is being trained by the seniors. ASHA का senior है village में आंगनबाड़ी workers, सब center पे multipurpose worker female, PSC पे health assistant female and medical officer. Functions of the counterpart of ASHA in urban area is USHA, urban social health activist, and the population coverage of USHA is 1000 to 2500, and on an average you can say it is 1 per 2000. Okay? ASHA it is 1 per 1000 and USHA on an average is 1 per 2000. Selection criteria, female 25 to 45, both ASHA and USHA, 10th pass not available, 8th pass, resident of the same village, having good communication skill, preferred is who can stay in the village, married, widow or divorcee over unmarried. She was a main worker for JSY scheme, that is Janani Suraksha Yojana, and aim was for promotion of the hospital deliveries, and she was given the incentive for each of the work. No fixed salary is there, but now recently the government has made the fixed incentive कि minimum इतना तो मिलना चाहिए. ठीक है? So you can just put a notice that minimum fixed incentive. Minimum fixed incentive is 3500 rupees per month. ठीक है? 3500 rupees per month. Like suppose there is no delivery, no work, and I shall say that I am not getting any incentive. So don't worry. So 3500 per month she will be getting minimum, and over and above more work, more incentive. So she is the main worker for GSY, which is for promotion of hospital deliveries. She is distributing contraceptives. She is an active surveillance for certain diseases. Home-based newborn care and home-based care of the young child, very important. Okay? So home-based newborn care is depending upon the place of the delivery, route of the delivery, the number of the visits. Now 7, 6 and 5, if it is a home delivery, starting from the next day, like today day 0 is the day of delivery, so next day 1, 3, 7, 14, 21, 28 and 42. Okay? But as if it is a hospital vaginal delivery, the next day patient is in hospital because discharge after 48 hours. So we will be starting from the day 3, 6 visits. If it is an operative cesarean, patient is in hospital for 5 days. So day 3 patient is in hospital, so we are starting from the day 7. Okay? So this is ultimately reducing the neonatal, indirectly reducing the infant mortality. And home-based care of the young child, it is after 1 month, means neonate phase is over. So irrespective of the place of delivery, the 5 visits on 3, 6, 9, 12 and 15 months. So that's why the impact indicator of ASHA functioning is IMR. Promoting hospital delivery, IMR will be less. Doing a good visits care in a neonate period or the early infants, referring the high-risk babies to the center, again preventing the mortality. She is also mobilizing the community to ICDS centers for attending the nutrition day. Okay? So nutrition day is conducted in ICDS once a month, and she is mobilizing the community, but ASHA never conducts a delivery. she is affiliated to the gram panchayat में एक committee है, village health sanitation and the nutrition committees. She is a member of that. ठीक है, because we are having a panchayat raj system में village level पे gram panchayat है and every member 18 plus is a member of the gram sabha. And उसमें से they select the some members as a for decision making as न्याय पंचायत and for health committees as village health sanitation and the nutrition committee. So Asha is a member for that. Block level पे we had a panchayat samiti and district level पे we had a jila panchayat. And India में we are having a separate elections for panchayat raj system. This is sort of parallel government we are having in the districts. Like we had a center and the state government, same is a parallel government in districts. Okay? But remember, Asha never conducts the delivery. Okay? Now, Anganwadi workers are the working in ICDS centers, and this is the logo of ICDS centers. Then the main beneficiaries are children. And children are not going alone, so they are going with mother, maybe a lactating or pregnant mother. Then mother is also not going alone, so bodyguards, maybe an adolescent non-school going girls or reproductive female. So she is a main worker for growth monitoring, immunization in the village, giving the midday meal, then referring the high risk baby to a higher center, giving them a non-formal school education, distributing the midday meal also, and giving the health education. Okay? So these are the functions of Anganwadi workers. Then ICDS centers are under the Ministry of Women and Child Development. Don't confuse. Agar question is asked, midday meal is under the ministry, so it is a Ministry of Education. Although midday meal is given in the ICDS centers also, and it is given in your the school also. It is under the Ministry of Education. But if they ask is what is the Ministry of ICDS centers, so it is under the Ministry of Women and Child Development. Okay? And the food what we are giving is, it is half of the protein and 1/3 of a caloric requirement of the child of that particular age. So it is additional to what the baby is eating at home, and this is the logo of midday meal, which is now called as Pradhan Mantri Poshan Yojana also. We are running certain scheme also for non-school going adolescent girls, making them strong by giving them, taking care of their nutrition, health, vocational services, literacy and all. And if they are undernourished, underweight, so we are giving them solid or uncooked food grains also. Okay? For undernourished girls, we are giving them 6 kg of the food grain per month also. Okay? Then we are having a multi-purpose worker female. She is a main worker for MCH care and conducting the deliveries at the sub-centers or taking help of conducting the deliveries at home, that is TPA. Okay? But sub-center may always remember only the low risk multi-gravida can be delivered. So the lowest center for the low risk multi-gravida, it is the sub-center. So this could be an integrated of question of obstetric and the PSM. So from the obstetric, you should be knowing which is a low risk, high risk, multi and primary. So low risk multi can be delivered here. The lowest center for IUCD insertion is again sub-center, because a multi-purpose worker female can insert. She is also doing an antenatal, natal and the postnatal visits. She is identifying the cases and doing the referral who needs MTP and tubal ligation. So she cannot conduct MTP, but she is referring the patient to PSC. So lowest center for MTP and tubal ligation is PSC. Okay? Now the blood test what can be performed at the sub-center, again it's a question, that is hemoglobin percentage for anemia, the blood sugar for gestational diabetes and urine albumin and sugar. Male is responsible for treatment of the common disease, but now it is treated with the community health officer, and who is obviously the senior for multipurpose worker male. Okay? Then he can be vaccinating also, chlorination of the well water, worker of active malaria surveillance. He is a worker of IMNCI program, means based on the clinical grounds, he is classifying the babies into the green category, yellow or the pink category, and preventing the mortality. IDSP project logo, very important. Every week he is filling the form, that is S form, which is filled at sub-center, and this is to report to the district hospital, and if any new disease is coming up, it can be easily treated. So S form from sub-center goes to the PSC, P form from the PSC goes to the CSC, L form, lab confirmed form from the CSC goes to the district hospital. So this whole track takes 1 week. So 1 week may from the sub center, the form is reaching to the district hospital. So early reporting of any new disease will be there, and he is doing the reporting for regular diseases like common diseases which are seen in that area. Then sentinel surveillance, it is for sexually transmitted diseases, and in that particular state if any additional new disease is there. Now he can now collect the sputum sample of a suspected TB case from the village. It can be collected by ASHA also, and it is sent to the designated microscopy centers for tuberculosis checkup. Okay. Medical officer is posted at PSC, and the school health checkup is a function of primary health center. ठीक है, primary health center का function है, and the he can be doing the minor surgeries under the local anesthesia like an episiotomy repair or abscess drainage or a wound repair, and that's why we say the lowest center for the delivery of low risk priming gravida where we require an episiotomy, it is the primary health center. Okay, and once a month he is conducting the meeting of all the members down up to the village. Okay. Then health assistant male and female, they are posted at PSC. Every week they are visiting to each sub center in that area, and randomly they have to visit the 10% of the houses also. So male will be supervising the function of a multipurpose worker male, and the female assistant will supervise the function of multipurpose worker female. Then community health center by we are having a specialist, means a post PG. So the lowest center for conducting the for high risk deliveries, okay, maybe primary or multi where we require a cesarean, it is the community health center, because we are having anesthetist also, we are having the obstetrician also, we are having the blood transfusion facilities also. So major surgeries under the anesthesia can be done lowest at CSC. Ophthalmologist is covering a 5 lakh population. So not every CSC has an ophthalmologist. If it is an extended or upgraded CSC covering a larger population, then we had ophthalmologist, and otherwise it is at the district hospital level. And all the specialists, it is per 1 lakh, because on an average the population of community health center is 1 lakh. Blood transfusion facilities, because it is first referral units are there. So this was in rural areas. Counterpart in the urban PSC 50,000 pe. Health and wellness centers, that is counterpart of sub centers, it is 15,000 to 20,000 population. And as sub center पे we were having multipurpose worker female, यहाँ पे है ANMs. So multipurpose worker female was covering 5,000, ANMs is covering 10,000 population. ठीक है. Polyclinics are 2.5 to 3 lakh population, and these are daycare centers where specialist services are available in urban areas. So confuse नहीं करना कि normally PSC पे we say the specialist is not available in rural area, but urban area में to decrease the load on the tertiary centers, we are having the polyclinics which are having the specialist, but day care है, वहाँ पे admit नहीं कर सकते, consultation कर सकते हैं. Second level care, metro cities में urban CSC for 5 lakh. And non-metro पे it is at the 2.5 lakh population. ठीक है. Now what are the public health standards guidelines or IPHS guidelines are? Doctors recommended is 0.73 per thousand, then nurse is 1.73 per thousand population, and the beds are 0.7 per thousand. Okay? If you can remember will be okay, but below this we have to remember. And ASHA recommended 2 per thousand, remember, but currently it is 1 per thousand. Okay? So no confusion should be there. Recommended, so ASHA ke liye we had not fulfilled yet, but for rest all we had fulfilled. So we know the center population, whatever the worker is posted there, that is indirectly the population of that worker also. Okay? So multipurpose worker male and female posted at sub center, their population is coverage is 5,000. Health assistant posted at PSC, coverage population is 30,000. Then lab technician and pharmacist 1 per 10,000 population. Okay? But ASHA and Anganwadis, they never conduct the delivery. Yaad rakhna. Okay? So this is about our this population norms as per the health standards. Now a few important points we can remember. The administration unit of ICDS in the rural area is the block, community development block, that is at 1 lakh, and tribal areas it is covering 35,000. So at least remember for the plain areas, okay? Not the tribal areas, it is per 1 lakh. And the Portion tracker, this is an app given to Anganwadi workers, and this is to track their beneficiaries like 0 to 6 year children, adolescent girls, pregnant and lactating women. What services we are giving to these beneficiaries. Okay? So this is about, we already had talked about as all the centers which are giving the primary healthcare services in urban and rural areas are called as now the Ayushman Arogya Mandis, and polyclinics are in the urban areas, urban PSCs के अंडर में है, and they are giving the specialist daycare services. ठीक है? So this is all in this video. The next topics we'll be having in the next link. Okay, bye bye, take care.